Okay, can everyone see my screen okay?
Yeah, I can see it clear.
Fab, thank you. Okay, so this is an interesting case for you guys tonight. I think you'll find the outcome quite interesting for this one. And it's going to cover something that we're not particularly familiar with, I think. So I'd love for people to contribute and give their opinions. So this is your maternal history. This lady is 27 years old, a gravida 1 paranormal. She's got a BMI of 32, a medical history of polycystic ovary syndrome. She's O positive and her virology and scatters NAD, and all of her bloods throughout pregnancy have been normal. She had an ultrasound scan at 33+6 for a reason that I can't quite figure out. But normal fetal growth, Lycor and Dopplers. Okay, so she attended triage on the 17th of the month at 39+2. Contracting 1 to 2 in 10, so suspected early labour. Blood pressure profile was undertaken as it was quite raised. I think the highest one was around 148 or 151 over the mid-90s. So she was given a statinofedipine for this reason. And then at 18:20, she was examined and found to be 1 to 2 centimetres dilated, posterior thick, and very partially effaced. What are we calling the baseline here?
140.
Yeah? 140, 135? Perfect.
130, 135, I'd say.
Lovely. Yeah, definitely agree with you there. Anything suspicious, anything suspect in this CTG? Anything concerning at all?
Is it like loss of contact, or is it maternal pulse, especially, you know, at like 1750? And then before, what is that actually? It's not very clear.
Not very clear at all. But you can see where the loss of contact is. The fact that the loss of contact is supposedly where that looks like a deceleration. We'd want to keep this on for longer. We'd want to monitor this trace for a little bit longer, wouldn't we? But the reassuring signs are there. We've still got accelerations and our variability is good. But yeah, maybe putting a maternal pulse oximeter would be a good shout in this case. But yeah, we wouldn't want to take it off at this point, would we? So I'll move on to the next one. So this is a continuation, sorry. So she's had PET bloods taken just due to that raised blood pressure. I think the PCR was normal in the end, but as PCR was sent as well. Mum's pulse is 105 on this CTG, but her PET bloods were taken and she was admitted to Hope Ward just with the raised blood pressure, but also for some additional CTG monitoring. Everybody happy with the plan?
Yeah.
Yeah, fab. Okay, so this was at 18:40 p.m. On the, what did I say, 17th. So we're now on the 18th of the month. At 05:20, the next CTG was undertaken. So she's now 39+3. And this is your CTG now. Baseline the same?
Yeah, still about 130 or 125 actually.
Yeah, 130, 125, yeah, but still within the normal range. No major differences between the first one. So we've definitely ticked off the box that this is no raising baseline, which is really good. We've still got our accelerations present, and variability still within normal range. And there is a lot of loss of contact there. Again, it would be great. Something I teach a lot of my students is to make sure we're putting maternal pulse on the CTG as well, so that we can clearly identify what might be mum and what might be baby. But it's much more difficult to interpret when we do have that loss of contact on here. But otherwise, no concerning features. So I think she's kept on. Oh no, she's not. She's taken off at the end of this CTG here. and then continued on our antenatal ward. I think she was reportedly contracting sort of 1 in 10, 2 in 10 at this point. They were quite mild on palpation, and mum was coping really well at this point. So she remains on antenatal ward. At 9 o'clock in the morning, the doctors do a review of her for 4-hourly blood pressure monitoring and to inform if medication is necessary, 6-hourly CTGs, and for an examination if her contractions increase, or for ARM if not spontaneously labouring, if the cervix allows for it. As you can see on this one, we're getting a much better picture of these contractions, which is great. Looking more like 1 to 2 in 10 now, much clearer to sort of see. But we happy with this CTG?
Yes.
Fabulous, definitely. And does anybody want to tell me something that's also reassuring about this one in terms of the variability?
A bit of cycling.
Absolutely. Yeah, so episodes of slightly increased variability and then slightly decreased as well, but within sort of normal ranges. And also that's a really good sign that the nervous system is all intact, because baby's going through those sleep cycles, and also there's cycles of more accelerative and reactive. And she's reporting movements as well on this one. I think they managed to find a CTG that had a clicker. Okay. So her contractions increased significantly on antenatal ward, and then at 15:20 she was examined and found to be 4 centimeters. At 15:30 she had a fresh APH of 50 mils, so was transferred immediately over to labour ward, where there was another 50 mils seen as she arrived. So now our sort of EBL at the moment is 100 mils, so definitely reason for keeping this lady on the CTG here. Looks like possibly more loss of contact, difficult to determine, but I think mum's pulse was sat at around 70-ish at this point anyway, so we could say that it's maternal pulse, but there's not a clear identification of that. And as you can see, she's contracting more like 3 in 10 now, so possibility that she's going to progress, which is good. So I'll move on to the next one. So we're continuing here. Baseline still the same, we're happy with that, and acceleration still present.
Yes.
Lovely. So we'll skim through a few of these guys because it does remain quite similar for quite a long while. This baby is remains quite well throughout the next couple of slides here, but stop me if we need to. So she goes out to the toilet at 16:55. Any concerns with this at all?
Is that still maternal pulse, Cara?
Difficult to determine, Paramdeep, because there was no obs taken within this period of time. So I would assume in this instance that this is actually baby's decelerating.
Right, okay.
Also with concordance with the contractions, makes it sort of more likely. But again, slight loss of contact, so slightly more difficult to determine. Again, if this ever happens, then it's definitely recommended that we put the maternal pulse ox on this mum, so that we can sort of see and identify that a lot more clearly. All right, but she's gone out to. Go on.
So just risk assessing this woman.
Yeah.
You've got a risk of obviously preeclampsia. You've also got a risk of APH on top of this. Have we asked ourselves if this baby's fit for labour, in the sense that is that a partial abruption bleed, and is this baby going to carry on, or what is the plan so far? So she's on the CTG monitoring, she's having blood pressures regularly and because of the blood PET, but are we risk assessing for the actual, is this baby fit for labour at all?
So the plan of action at the moment, Saoirse, is basically just to our sort of sit and wait approach, so examine in 4 hours time. But I don't think she was reviewed by the doctors at this point. I don't think they reviewed her until a little bit later on. But due to the fact that she'd progressed quite well in the labour, I think there was maybe an assumption that the bleed was due to some progress. but the bleeding had stopped at this point, and the continuous monitoring was recommended. So that's pretty much what happened.
Okay, it's just interesting when a risk changes or something's added, having the importance of having that. Okay, something's been added. Let's have an obstetric review, because now you're adding on to that preeclampsia that she could potentially have an abruption because of the high blood pressure to her. What was her booking blood pressure?
Normal, like 110/70.
Okay, so it's sort of substantially larger than what it was. Okay, fine. Thank you. Sorry.
Yeah, no, it's fine. But also her blood pressure had normalized while she was on the antenatal ward at this point. I think once she'd had the statin nifedipine, there wasn't many raised blood pressures after that.
And just to ask as well, sorry to be a pain, why did you give nifedipine and not the Betalol?
That is a question I don't know the answer to, I'm afraid.
Okay, fine. Thank you.
That was what was recommended by the SHO, I think, that reviewed her in triage.
Sorsha, I mean, I don't know what this case is, but just to say for the nifedipine, it might be because of her ethnicity. I'm just throwing it out there. I don't know who this woman was, but it could be because of her ethnicity, which is why they gave nifedipine instead of labetalol. But I don't know.
I was thinking that, but in pregnancy, I know there's some research recently. Someone's gonna tell me otherwise because I'm not up to date with it. But I would have thought that labetalol would have been the first course of action, despite ethnicity. But I could be wrong. I don't know. There'll be some research out there. I just don't know it.
Mr. Naguibel-Meyer, do you have anything to add to that?
Yes.
I don't have. Oh, sorry, Mr. Naguib first.
No. Please, Maya, proceed. I'm driving anyway, so please.
No, because I don't have any research or evidence. But for example, I know this lady was in early labor, and obviously nifedipine, even though it wouldn't stop it really, but in a way it's tocolytic. But at the same time, labetalol is going to give me a lower baseline, and the mom was tachycardic. So it could be masking the tachycardia, the one that you mentioned on the 17th. Her pulse was 110. And then obviously I did not kind of follow if that remained tachycardic or not. So I don't know. I'll leave it for Mr. Naguib to say the evidence. But everyone, if you're using either agent, for me, I would want to kind of keep an eye on what I'm trying, what the side effects I want to dodge, and what side effects I want to kind of keep an eye on. So am I going to suppress the baby's baseline? It's going to have like a labetalol effect, or am I going to kind of like slow down her labor a little bit? So but evidence-wise, I leave it to Mr. Naguib. I haven't got any kind of recent data, to be honest.
For me, you could have given labetalol. It's okay. So the NICE guidelines say labetalol, nifedipine, and alpha-methyl dopa as the third one, but they say labetalol first and nifedipine second. But to be honest with you, there is no preference, and it is according to the one who is giving the preference-wise. And the usual that we usually do when somebody is already on labetalol is that they have the nifedipine, and if they are on nifedipine, we give labetalol. So I mean, you can use either or.
Okay, amazing. Perfect. I'll continue then, guys. So this is now about 5:05 in the afternoon. She's using Entonox to support her with her pain relief options. I think it's becoming possibly slightly clearer that actually these query loss of contact / decelerations do appear to be more like decelerations with this trace, because we've got a lot better contact on this one. Does anybody want to try and classify these types of decelerations that we're having here?
Chemoreceptors?
Yeah, I agree that there's sort of the good news is there's good variability within the deceleration, which is a reassuring sign. But yeah, they are quite long, and they're not necessarily slow to recover, but they're more sort of shallow in looks wise. So I would agree with you there, Sasha. I don't know if anybody would disagree with that one. But yeah, so it's something that we're going to keep a very close eye on.
I think looking at the contractions as well, so it's really important when we're looking at the decelerations, we're looking at what the toco's saying as well. So here, is it uterine irritability, or actually is that toco not working? Have we palpated ourselves? If she's using that Entonox, is there a change in the type of pain? Again, going back to those risk factors of query PT, query early abruption, or what is that whole clinical picture?
Yeah, absolutely. I don't know, the toco was picking up beautifully when we were on antenatal ward, but for some reason it's not working very effectively here. Just as a sort of side note, just to highlight the importance of palpating our contractions, you know, they're not always felt the most obviously at the fundus. So when we're putting that toco monitor on, making sure that we're clearly identifying that it is going to be in a place where contractions are going to be picked up, and if this sort of thing arises like you can see, then just making sure we move it just to see if we can see it better. But also, as much as we love technology, and I say this pretty much every single week, making sure that we're palpating the uterus ourselves for a period of at least 10 minutes and making sure we're documenting if we're feeling resting tone. Specifically in this case, because this lady's had this APH of 100 mils, we want to make sure that our uterus is being palpated to ensure that we're not missing anything. This hasn't been done as yet in this case, from what I can see on the documentation. But please do make sure to do this and identify this within your handwritten notes as well, everybody. But we've got still a nice stable baseline and good variability, which is reassuring with this, but we're not going to do anything drastic at this point in time. So blood pressure was taken at 1735, blood pressure 131/84, pulse of 86, resps of 20, temperature of 36.6 and SATs of 99%. She's cannulated here at, as you can see, around 6 o'clock. I'm assuming purely for the fact that we may need to either give some medication through the cannula, but also possibly due to some CTG concerns. But she's on labour ward, so we tend to put cannulas in for every reason. But also she's had an abruption. We want to make sure we've got intravenous access. But this one, are we happy? It looks much more normal than the previous ones. It looks like baby's kind of settling here.
Yeah, it looks normal.
Lovely. So we'll continue. So at 6:15, this woman starts vomiting. I think this at approximately sort of 300-400 mils. She starts feeling better, I think, after she has vomited. But following on from that, CTG kind of returns and stays where it is, and she goes out to the toilet again as well. This lady goes out to pass urine very, very frequently, which I found quite interesting. I don't quite a lot of urine, so possibility that she was slightly urinary retentive when she was on antenatal ward and whatnot, but just something to make you all aware of. So we'll continue. This is your CTG now. Any thoughts?
Any signs of fetal activity? Is she reporting fetal movements?
She is, yeah.
She's saying fetal movements, so then I'd be reassured by that. Even though it's sort of quite difficult to interpret, I would be reassured if I can see fetal movements, if she's saying that she's got fetal movements. Potentially that could be baby being active. Again, what's happening with the contractions? Has she strummed yet?
No.
Okay, fine. So I'd monitor if there's any more lochia. I'd monitor her in general. But if there's fetal movements, it's quite reassuring because we think happy babies move, poorly babies don't.
Yeah. Absolutely. Okay. So at this point, she's actually said that baby is not moving very frequently. She's gone out to the toilet again at 19:24. Declined bedpan, I think. Does anybody know why in this specific segment of CTG we may have recommended she stay on the monitor?
It looks just like the section before. So yeah, I don't know.
Is it because of the loss of contact? I don't know if there's a raising baseline, or is it too early to say? Or
The contractions as well, and the fact that is her baseline 130 with accelerations, or is her baseline essentially 160 with decelerations? It's hard to interpret. Again, if she's saying she's got reduced fetal movements, again, that's another added risk factor, so we should be risk assessing. I would potentially keep her on. Are we, when she's going out to the toilet, are we measuring the urine output? Is she
Yeah.
IV
No,
fluids?
they're reporting good urine output every single time, but no fluids have been started. So this is all based off what she's been orally hydrating with.
Was there a fluid balance commenced at any point so we can see the in and output?
No, I don't think so. The thing that kind of struck me here a little bit is in the previous sort of segment, she's reporting movements, but then it is documented that it's decreased. But to me, this looks a little bit like we're accelerating with contractions.
So what's maternal pulse?
Maternal pulse was last recorded at about 35 minutes past 5 and was 86.
If we're querying accelerations with contractions, it would be an indicator to take maternal pulse because you're querying whether or not that's mum or baby.
Yeah, absolutely. So again, the maternal pulse oximeter would have been quite a good thing to have here. I've written down all of the observations that were taken on this lady are in these slides, just to sort of point that out. So definitely would have been good to sort of justify whether or not we are actually recording maternal heart rate or if we're recording fetal, because it's very unusual that a fetus accelerates at the same time as contractions. We see this happen. I've noticed a lot more recently. This has happened quite a lot more than I've ever seen before in the last good few years. And people do come and sort of tell me about these cases, and they say this was a very bizarre one, difficult to interpret because it looks like accelerations with contractions, but at the same time, is it actually that our baseline's higher and that we're getting deceleration? So Mr. Naguib, I don't know if you've got, or Maya, I don't know who else is on the call, but I don't know if you guys have any sort of suggestions here, because if we took the contractions out of the way, this would possibly look like a very, very normal CTG. But when we take everything into account and the whole clinical picture here, it's a bit of a different story.
Sorry, Cara. Your question is about contractions, acceleration during contraction.
Yeah.
You know, I know you showed me in the book that it can be a significant thing for like neurological instability or something. You showed me on the CTG book.
Yeah.
Yeah. I personally, you know, take it in the context of the whole situation. Yes, it might be showing me some sort of that it is maternal, but if it is not maternal and it is fetal, personally, I don't know. Personally, I don't give it any significance. Personally.
Perfect. So just to sort of throw a different perspective into this mix here, because this has happened quite frequently when I've been shown cases like this quite recently, I've done a little bit of extra research into accelerations with contractions, and I've only found a couple of studies. It's not something that's particularly looked into, I don't think, but there is some evidence to suggest that accelerations with contractions could actually be as a result of fetal convulsion, so fetal fits, fetal hypotension, so low blood pressure, and fetal panic. So it's something just based off of that one study. This isn't me saying everybody should panic whenever this situation happens, because obviously we've got lots of other reassuring signs on this CTG. I think if we didn't have other reassuring signs, then we'd be slightly more concerned. But just based off of a piece of research that I've read quite recently, I just thought it would be good to contribute to this case in particular. But like Mr. Naguib said, you know, it's CTGs can be open to interpretation, and sometimes it is difficult to tell. But we'll move on. So this is now your next segment of CTG. So this is now 1935 to 8 o'clock. At 1938, this woman is re-examined and is found to be 3 to 4 centimetres. We're now getting close to handover now. So I think due to ward activity, I believe that's the reason that there was a delay in getting a registrar review as well. But obviously could be seen on the central monitoring system. What about this? Are we saying at the moment the baseline's 160 and these are D cells, or are we saying this baby's accelerative? Because at this point, no fetal movements have been documented.
I think it looks like baseline's 160 with D cells, but then it's really confusing.
Yeah, I agree. Would anybody else like to try and interpret?
Abnormal CTG. Reason being is you've got uterus is contracting more regularly than it was. You've also got potentially maybe signs of decelerations at the start of that. You then again have to take the whole clinical picture into account, the fact that she hasn't progressed from her previous examination. She's got obviously still got raised blood pressure. Yes, it's not treatable raised, but it's raised from what her booking was. You've got another indicator of potentially your variability has changed from what it was. Now, my signal went, I'm driving as well, so my signal went when you were talking about the accelerations in contractions, but I don't know if you mentioned subclinical chorioamnionitis. Can't get my words out. But that when you start having accelerations with contractions, and then it's sort of proceeded with increase in variability, which is not normal for this fetus, what it previously was, that could be a sign of infection. Now, subclinical chorio, you may not always have maternal infection, and if she hasn't strommed, again, you haven't got signs of offensive liquor, but the CTG showing you potentially a change. And that's why sometimes it's difficult when you're interpreting these CTGs. You're not necessarily thinking hypoxia, but you're thinking, okay, what's the whole clinical picture? Have things changed? And again, our risk assessment again has changed, and we should be risk assessing more often. I don't know what it is, Croydon, maybe it's 4 hourly, I don't know, but it's that risk assessment. Okay, another thing has changed. We're adding to that picture. We're adding to that basket of risks. And how is this baby doing? Is it fit for labour? Can we continue? So I would definitely say potentially have a obstetric review with the sign of having that discussion with mum as well. How far have we got? We've got another potentially 12 hours of labour. Can this baby cope? That would be my argument. Again, human factors, 7:30. You know what's coming.
We know that handover is going to be there. So it's going to be for the night team to sort of make a plan going forwards. Does anybody have any other comments on this at all?
I agree with Sorsha, actually, Cara. You know, that the whole clinical situation here, and with the baseline, and with whether it is deceleration or acceleration, and you know, yes, and still 3 to 4 centimeter. So we need to be aware of the whole clinical situation.
Perfect, thank you. So I'll show you that this is your next segment now. So at 2025, it's reported, so the midwife has documented that she's been palpating and this woman is contracting 4 in 10. She goes out to the toilet at 20:30 and blood pressure is now 138/89, pulse remains 87, resps of 18, sats 100 and temperature of 36.5. In this instance, because we do have CTG concerns, we would definitely, I think, again, I think we will probably all be in agreement that a bedpan may be recommended, as opposed to getting up and taking this CTG off. If we've ever got concerns that this is an abnormal CTG, trying to encourage the woman to stay on it would be greatly encouraged. Obviously, this woman is absolutely entitled to come off if she wants to, and she wants to go and pass urine in the toilet. But just as a side note, just making sure that we are carefully and safely monitoring this baby, specifically if we've got raised suspicions about it here. But yeah, it continues pretty much similar to the previous trace here, as we can see. And yes, still difficult to determine the baseline. And again, we're questioning, like Saoirse said, is this baby fit for labour? Are we going to try and add any additional stress to this baby to try and help her progress? Because obviously she has remained the same. No is the answer. So I think at this point, making a plan is increasingly more difficult, but we're going with a sit and wait approach and waiting for the ward round to determine what we do next. So I'll continue. So at 2050, the anaesthetist is present for an epidural. This lady is now contracting regularly and has requested it. And at 2100, some loss of contact is recorded. So kind of in the middle of that last third there, just while she's sat up waiting for her epidural. I mention this every week as well. I'm sure you're all sick of hearing it, but making sure that we've got fetal heart rate maintained on the CTG throughout the entire epidural siting process is super, super, super important, specifically even more so when we've got concerns re this CTG. But it looks a little bit like it's starting to normalise slightly here, which is reassuring. Baseline is becoming much more evident. We've still got good variability, which is great. But yeah, we'll keep a close eye. Does anybody want to add anything? Okay, I'll move on. Epidural test dose is given at 21:10, just where the box I've written in is there. And then at 21:32, an indwelling catheter is inserted. And at 21:35, due to the fact that the CTG has normalized, this lady is examined and an ARM is performed. I think I'm sorry I didn't put the centimeters down there, but I think it's still the same, 3 to 4 centimeters. But her blood pressure, as you can see, after her epidural was raised slightly, again at 141/96, with her pulse of 89 here. Happy to continue?
No.
Yes.
And the reason no. The reason why I say no, I'm horrible, aren't I? I should have been an obstetrician. The reason why I'm saying no is because yes, okay, it's arguable that the CTG has normalised. We've got periods of cycling here. Now, again, we have to think about that whole clinical picture. You've changed positions for epidural test dose, but the actual clinical picture hasn't changed. And post epidural, having a blood pressure that's higher, one is you have to look into that. Again, there's research behind this, but you have to look into why the blood pressure is raised post epidural as well. So again, we might have fluids on board. Obviously, she should not become hypertensive. But again, why is that? Have we done PT? We did PT guys. Were they normal? Did we do bile acids? Did we look at that whole clinical picture? So I know where we're going, and I think we've got a false sense of reassurance by now saying the CTG is normalised, but the clinical picture hasn't. And if her VE, again, she's what, nearly 12 hours? I can't remember when we started the VE. No, it's not. It's about 6 hours, isn't it? So she was 4 centimetres initially. But again, she hasn't made any progress in established labour. Again, we have to think about that APH, we have to think about the blood pressure, we have to think about where we're going. So even though the CTG we say is normalised, the whole clinical picture hasn't. And actually, are we pushing this fetus unnecessarily? She's going to end up with an SVD, and I'll bite my words. But at the same time, again, it's that whole clinical picture, and I think that's really, really important to know.
Saoirse, can I ask a question? I get everything you're saying. So at this point, though, like looking at her CTG like this, what would your plan then be? Because a CTG like this, like you can't be like, oh, okay, we're going to section you, because arguably, like you said, it's a normal CTG. I get her clinical picture isn't, but then what would your plan then be going forward from here?
It would be that discussion with mum, and yeah, offer a cesarean. section, because what are you doing? So here we said the CTG is normalised, but yet our baseline is whatever, I can't see it, 13130.
Yeah.
But yeah, and with ARM, so again we're going to put more stress onto this fetus, so it's anticipating what the next step is. The reason why you go for a sort of physiological approach with CTGs is we're looking at what the next step is, and every time you do something, every time you do a fresh eyes, you should be thinking, what is the next step? What am I anticipating the CTG is going to look like? Because in the next hour when I do my fresh eyes, what will that be? Will it be normal because I'm anticipating a low risk, whatever the normal situation is? But with this one, again, we've already got risk factors. Think of it like a basket. I've got my basket, I've got my risk factors. What is the next hour I'm going to bring this basket in? If I've done an ARM, yes, it's clear at the moment, but actually I'm going to speed up the labour. How is this baby going to cope? Are we going to have more signs of an APH? Are we going to have a rise in the blood pressure? How are we going to treat that? And are we going to get to a stage where we've gone too far? So CTG is only one element of it. So I would have a discussion with mum. Yeah, okay, fine.
Okay.
Yeah, I'll just,
Cool,
it's that
thanks.
review, isn't it?
Yeah, no, it's just good to hear your thoughts. Thanks.
Perfect. So this is your now next slide. Blood pressure still raised 143/83, pulse of 94, resps of 18, sats 100%, and temperatures 36.7. Contractions look a bit like they've more frequent now as well. So I don't know, you could argue they're still sort of 4 in 10. Look like they're lasting a bit longer from here as well, but we've got some decelerations thrown in there as well. Anyone who classify these ones?
It's interesting to note as well, when you have decelerations, how the fetus is recovering in between these decelerations as well. And again, you've got that increased variability in between those two. So you've got a period where you've got four or five contractions, and then you've got the fetus recovering to it. So this is a really good eye-opening experience, because actually you can see in that 10-minute segment in the middle, you've got 2 decelerations with increased variability after. How is this baby coping? What do we think? Sorry, Cara, I haven't really answered your question.
No, you're fine. It's always good. It's good. Yeah, and there's signs that there's sort of the evidence sort of suggests that when we've got increased variability, that can be a sign of fetal panic. So is this baby trying to protect itself, decelerating, panicking, decelerating again, and then exactly what's gonna happen next, essentially. But this baby does sort of cope with it well, because following on from those two decelerations, we're getting back to what it was previously and what it was in our earlier traces as well, despite the whole clinical picture. The CTG in itself obviously appears normal on either side. So continuing on, blood pressure's now gone up again, 147/96, pulse 100, resps of 18, and sats of 99%. They didn't do a temperature on this round, and I'm not quite sure why. But routinely, we wouldn't need to do it more than 4 hours apart anyway, as part of our standard labour observation protocol. However, with the concerns that we've had raised, I would definitely recommend doing it more frequently than is recommended in the guideline here.
Cara, was she given any more antihypertensives or just that statin nifedipine on admission?
No, she was just given the statin nifedipine on admission. There's been no other medications given. Although I don't know if the obstetrics were working on the theory of wait till it's over 150/100.
Okay.
Epidural is working effectively as well, so we know that the likelihood is this isn't pain related. So again, whole clinical picture. Mr. Nicky Meyer, would you have treated this with some kind of medication?
I would, yeah.
Yeah. What would your first line be here, Mr. Naguib?
I would give, if she is on regular labetalol, I would give her medication. And if she is not, then I would give nifedipine.
Perfect. So she wasn't on any regular medications before, but yeah, so first line labetalol in this situation. Okay, and she's contracting now 5 and 10. So let's just bear that one in mind when we go forward. We've still got a stable baseline and we still do have good variability, but we're going to keep a very, very close eye on this because there is a possibility that concerns may be coming with this trace. So I'll move on. IV fluids have now been started. I don't know whether this is the second bag or whether this is the first bag, purely because it's not documented when the first bag was given. So, side note again, please make sure that we're documenting when the first bag of fluids have started. But I would assume that it was started with the epidural, and that this was the second bag given here. Sorry, I've left a number off of that blood pressure, but I think it was 91. 138/91, pulse is 85, and otherwise all normal. Happy to continue. Any concerns? No, I'll move on then. At 23:30, fresh eyes is done with one of the other midwives, and the CTG was classified as normal. Do we agree or disagree in this case?
Can you take it back so I can see the previous hour? Because I can't actually remember what it looked like.
Do you want me to go back further?
Just one more slide, yeah, because then I think that will be the hour. Okay.
Oh
All
yeah,
right, fine.
sorry. I'm so used to, because when I take the photos of them, as dodgy as they are, there's normally a bit longer of the CTG in it. Cool. Erica, what do you think? Would you sign this off as normal?
I think I would, yeah. The baseline is the same, it's accelerative. I know she said, yeah, I think I would.
Yeah, anybody agree or disagree?
I feel it is more saltatory pattern near the end, really.
Yeah, towards the end looks like it's getting there, but from the last sort of hour getting up to this point would be classified as normal. But yeah, we'll soon see if this continues here. And her blood pressure's come down slightly as well, which is good. So we're continuing. At midnight, blood pressure's gone back up again. 136/90, pulse of 95. So her heart rate's now increased as well. I'll continue because I don't want to keep you guys forever. 0007, she's found to be 7 centimeters dilated and now has blood-stained liquor. Pulse 89, so it's gone back down. Blood pressure's reduced slightly to 129/78. Tell me to slow down or stop, guys, but I fully appreciate the fact that this one's been taking quite a while. So we'll continue. Second bag of Hartmann's is started, so I forgot about that. So I do think the first bag of fluids maybe wasn't started with the epidural, which is another quite significant concern. But blood pressure is now 145/87, and maternal pulse is now 118. What are we thinking impression-wise?
CTG is normal.
Yeah.
Yeah.
Decelerations are still less than 50% of our contractions. But yeah. Okay, continuing on. She's still contracting 4 and 10. Pulse remains high. Fluids, second bag of fluids is running. A good urine output was reported as well. What was our previous baseline?
The baseline's risen because initially it was 125, wasn't it? It's now gone up to 145. So are we thinking infection or?
Possibly, yeah. So the baseline sort of varied, sort of around the 130, 125 mark. So we're not quite at a 10% increase just yet, I don't think. But we'll continue. Blood pressure remains pretty similar to the way it has been. And our contractions also are coupling now. So again, making sure that we're palpating that resting tone and documenting it. We'll continue.
Are we near any examination, or we are still far from it?
We're still quite far from it, I think. So at midnight, she was 7.
Right. Okay. So 4 o'clock. Okay.
Yeah, so 4 o'clock.
Just to note as well, her pulse is 120. Now
Yeah.
we're starting to have signs of obviously clinical chorioamnitis now. If she's having a rising pulse and the baby's now having a rising baseline as well.
Yeah.
So I think it's really important to note that actually what we mentioned earlier of where we're risk assessing, it's now sort of coming true. So I think this is again another risk assessment we need to do. We need an obstetric review potentially, and we need to argue again, CTG is only one aspect of it, but it's showing us all the signs.
Yeah, also reporting blood-stained Lycor too. So if we go all the way back to the beginning where we had that APH of 100 mils, is that Lycor that's blood-stained as a result of possible placental abruption? Is that the direction that we're heading in? Are we heading in the choreo direction? So at 02:30, so I'm just going to cover the protocol very quickly, but our sepsis protocol or our screen and treat protocol is 2 temperatures of over 37.5 or 1 of over 38. However, taking the whole clinical picture into account here, we're probably going to want to do a septic screen, as considering as well her pulse is over 120. Despite the fact that she's not hit the sort of category for it, well, she has because of the pulse, but in terms of temperature wise, we're going to want to start maybe taking some additional bloods, giving her some IV paracetamol and some antibiotics. At 2:30, she started shivering. So we've got to a point now where it's becoming quite evident that this woman's quite unwell. Baseline's now risen up to about 150, so we have gone above that 10% now. Blood pressure remains raised.
Are we doing anything about blood pressure? Have we treated it yet?
No.
Antihypertensive, just leaving it?
No, just left it.
Okay, fine.
So we're continuing. So at 02:40, patient is moved to right lateral.
So they didn't screen and treat her.
No.
I get the protocol temperatures above 37.5 or whatever, but if a woman's pulse is increased, if she's tacky, then we need to use our heads and we should also screen and treat.
Absolutely.
Because
So
like the pulse is high, the baseline is high, she's shivering. But that alone, with her having a normal temperature of 37.4, I mean that's on the high side of normal anyway. But you know, that's enough. Her pulse, the baseline, and her shivering, that's enough for us to think, oh, she's got an infection.
Absolutely.
And I wanted to remind also people about one other cause of tachycardia, which is obstructed labor. So we always concentrate on choreo as the main reason of tachycardia, but also obstructed labor is one of the reasons of tachycardia.
Thank you, Mr. Naguib, definitely. Okay, we're going to continue. At 03:18, the midwife in charge is now present alongside the consultant. So this is it's now been a while. She's been tacky for a good couple of hours now. So from about midnight, she was tachycardic. And we're now at 3 o'clock in the morning. 03:18, the plan is for a septic screen and IV antibiotics alongside IV paracetamol. At 03:30, she's examined and is found to be 4 centimeters dilated. So slight contradiction from that 7 we had at midnight. Caput plus. An IV paracetamol is given here to help try and support this woman. But if we think as well, this woman's been shivering, this woman's been giving us signs that she's significantly unwell, Let's not have to wait for the midwife in charge and the consultant review. Escalate it to any of your colleagues. Ask for their clinical opinion and judgment. Also, obviously, inform the midwife in charge and the consultant at the time that you detect that there could be an issue. Yeah? So what's our baseline now?
Mate, it's 180, 175, 180.
Yeah.
She needs to be delivered at 4 centimeters as well. She needs to be delivered.
Yeah, so she's been 4 centimeters now for, I think, roughly 12 hours.
See, look, should have sectioned when I said so 6 hours ago. See?
Yeah, but Sorsha, that was basically a normal trace. Come on, at the time.
No. Right. Okay. So this is why this is the argument, and this is probably why the section rate's going up. But you have to look at that whole clinical picture. At the moment, we've just basically said everything 6 hours ago. So now it's like we're walking into chaos for this baby. And you think about the input for this neonate and how this neonate is now going to be impacted with IV antibiotics, etc., because it's living in a oven.
No, Sorsha, I 100% agree with you, because obviously we can see now where the woman has ended up and what her situation has turned out to be. But the section of the trace that Cara showed us 6 hours ago, where it had improved after her epidural, I know you said that at that point you would, talk about delivering, but at that point, like even like any registrar would see that part of the CTG and they're not going to say, oh yeah, let's take you for a section, because in their eyes, like it's normal. Like it's not, it was abnormal, it's now normalized. But I get everything you're saying.
I could do this all night. But again, it's looking at that whole clinical picture, and the CTG is not just the answer. We're looking at a CTG to add to our clinical picture, not to be the primary cause. And now we're looking at it again as the primary cause. We're walking into a room looking at the CTG, then looking at the woman, when we should always look at the woman before we look at the CTG. And it's interesting, Cara, actually, the last couple of hours of fresh eyes, it'd be interesting to do a little mini audit to see actually was that classified as normal when you've got that rise in baseline, when you've got that change in risk factors, because every time they're doing a CTG fresh eyes, they should be adding these risk factors. But a lot of the time they will just do latent labour, or it's really interesting. So maybe when you're doing fresh eyes, it's clicking all those buttons on Cerner to say, right, she's now got 7 risk factors. Are we maybe reviewing that? But yeah, it's a really valid point. And
this one is in my audit, don't worry.
But Erica, you are right. And I know if I came to you at 8 o'clock and I said I want to section her on a normal CTG, you would laugh at me, and it would be completely justified because I get it. But again, it's looking at that whole clinical picture. I bet you guys are so glad I left.
Yeah, no, don't be silly, Sorsha, not at all. I get it, but then also I think like back 6 hours ago, like she wasn't septic then. The baseline was still normal. So it's just obviously now things have progressed, and we knew where things were going anyway. It's just at that time, obviously now we have more of a reason to section her, but it's just at that time it was like we can actually wait for a little bit longer just to see if things change, and obviously they have changed.
I would say also a balanced opinion between the two opinions that we are hearing, which are both valid, is she is not the only laborer. There is other laborers. There is other people having C-section in the middle of the night. There is less staffing sometimes. There is maybe somebody else in theater, somebody else who's having instrumental. So it is not a solitary patient in the helicopter view of the labor ward really. So it is not only dependent on the CTG and her progress and her delivery and so on. You balance and you prioritize.
Absolutely. Always think about the human factors. Okay. So at 0350, IV antibiotics are given, and the decision is now made for a cesarean section. I'm sure we're all very relieved. So so the decision was made at 350. Pre-meds were given at 0420. And now we're in theatre. At 0502, thick meconium is seen on the woman's pad. At 0507, we've got knife to skin. 0510, knife to uterus, and baby is delivered at 0512. Does anybody want to guess the APGARs and the gases of this baby? And does anyone want to define this hypoxia?
Was it GA or spinal?
Spinal.
There's your answer. it's always interesting if they document when the spinal went in, because usually that's when you have this reaction.
That's my bad because I didn't
No,
put
it's fine.
that.
It would have been
the-
about 5 o'clock, wouldn't it? It would have been when they saw the pad. That's usually when they're moving it. So if you think about 5 o'clock,
Yeah.
and then look what's happened. If you think change of position as well, if you've really got an abnormal CTG and you're laying there supine, what happens obviously is placental perfusion, and go from there. Oh, what a beautiful CTG.
Who wants to guess the gases? I know we've got student midwives on here. You can guess the APGARs. I want to know what your thoughts are.
7.12 and 6.9 with high lactate, and a base excess that's maybe -6 or 7. APGARs might be fine. Actually, probably not. APGARs 6, 10, and 10.
I would go for 7.15 and 7.1 with normal APGARs, but the baby is sick because of meconium and choreo, and admitted to SCABU.
Okay. Anyone else? Erica?
Yeah, I'm gonna agree with what's been said. I can't. Yeah, gas is round about the same. 7.1, 7.15. Yeah, 7.2 at a push. APGARs. I don't know, because some of these babies, I feel like they'll come out crying, but then, like Mr. Naguib said, they'll be unwell. So yeah, I don't know. 7, 10, 10 maybe.
7, 10, 10.
Yeah, I'll go with that.
Can somebody name call somebody else because I can't see who else is on this at the moment.
Paramdeep.
I don't think I agree with the gases. I was going to go 8, 9, 10 there for the APGARs, but just maybe needed stimulation because of the mech. But the gases I agree with.
Perfect. Any student midwives want to give it a go? I know you're on there. Okay, I'll put you out of your misery then. Baby was born with APGARs of 5, 8, and 9. Arterial pH of 6.91, base excess of -11. Venous pH of 6.97 and base excess of -9.5. I'm so sorry I didn't put the lactate on there, but this baby was admitted to SCABU immediately from theatre.
Was it called?
No.
Okay. It's interesting, the gases being that low. And what does the obstetricians think in regards to, do you think this is a good call for section at this time, or would you have sectioned earlier, now looking at the outcome?
We agreed, Sorsha, that we wanted to section earlier because of the staying 4 centimeters. So I would have said, yes, we would have sectioned not because of CTG concerns. I would have sectioned because of the overall clinical picture.
Thank you.
Sorry, Mr. Naguib, can you say that again?
What I'm saying is the CTG itself, I think it is a good call at the point of call. But if I am assessing the whole situation, maybe I would have sectioned her at 12 o'clock or so.
Yeah.
Yeah.
Perfect. Does anybody have any further questions about this trace at all?
Yeah, just quickly. So baby was admitted to special care, I'm guessing for antibiotics, but what else, was there any findings from